It's so good to see everyone. Welcome to the 2025 Women Veterans Seminar. I want to thank everyone for coming, and you guys are in for a special treat. We did a lot this year to make sure that this can happen for you. I'm going a little bit off script, though. I heard someone say, uh-oh, I know, Naomi's going off script. You already know. So before we get to the actual formalities of it all, we had some women come up to us, women veterans come up to us and say, you know what? We want to recognize the fact that we're two leaders in the room that we don't get to have in the room quite often or as often as we would like, together. Let me say this, together. And so there are two women veterans who have really led the way, and we have our first ever past national commander now, Delphine Metcalf Foster. There you go, that's right. Take your bow, that's right. And then we have, she broke the ceiling and blazed the trail and led the way for us to have another women veteran as the past national commander, Nancy Espinosa. We have a very small token of our appreciation for everything that you have done and for what you continue to do, because one thing about the two of them, it's not just, oh, they got the title of National Commander. It's not about that, but they continue to mentor, they continue to teach, they continue to lead the way and show us this is what else it looks like after all of the accolades, after the curtain comes down and the lights come off. They're still leading. They're still blazing the trail. And so we have something. This is a poppy, or forget-me-not, really. Actually, I think it's a poppy. Hold on. Where is Sheila? Sheila, are you in the room? Sheila, come here. Sheila's gonna come and explain exactly what this is. It's beautiful. I know it's tiny, y'all can't see it, but it is absolutely gorgeous. Sheila, go ahead.
All right. So a lot of women veterans got together and said we need to acknowledge the milestones that our other women veterans have done. So we found this pin. It comes from the Military Women's Museum in Arlington. It is a forget-me-not. It's a brooch. It's a forget-me-not. So it ties in DAV. The color of the forget-me-not is a purple, but the purple was made from every branch of the service put together to come up with this purple color. I know I'm forgetting something else. Oh, and it's handmade. So the person who designed this designed it exclusively for the Military Women's Museum Memorial. So sorry, thank you, Shannon. And it's handmade by Ann Hand. And Ann Hand has made many brooches and pins for different U.S. department, like Department of Interior. She's made pins for senators' wives. But she's probably made pins for over 30 departments within the United States government. So there's also significant that a woman created this, and I think there's so much significance to this pin, to giving it to our leaders.
So if we could get, actually, I'll come to you. How about that? right, so good afternoon. Now let's get to the formalities of it all. I'm DAV Assistant National Legislative Director Naomi Mathis and the moderator for today. A few housekeeping issues. Let's go ahead and silence those phones, please. Push-ups, you already know. There will be push-ups for any violators. Y'all know me. Today's seminar will focus exclusively on women veterans' whole health, including cardiovascular health and mental wellness. Well, that's me. There are readjustment counselors in the back of the room and outside with the Vet Center table. If you need to speak with someone, please. We have the counselors on hand. Go ahead and see them. We have private rooms for discussions. And to the RCS counselors in the room, I want to thank you again for supporting us this year. I do have a wonderful program for you, so let's go ahead. I would like to begin by introducing the members of DAV's Interim Women Veterans Committee. Ladies, as I call your name, please stand and be recognized. Our chairwoman from Louisiana, Ms. Belinda Hill. From Connecticut, Juliet Taylor. From New Jersey, Jennifer Alvarado. She's somewhere around here. Oh, there she is in the back. Look, working. From Massachusetts, Andrea Gale Bennett. I want to thank the committee members for their work and for putting up with me, honestly, over the past year. Please, let's go ahead, just as a collective, give them all a round of applause. And is Sham in the room? Shamala, are you here? No, she's probably ripping and roaring somewhere, but I want to thank Associate National Legislative Director Shamala Capizzi for her help with the committee this year as well. Now, if you are Department Women Veterans Committee Advisor, will you please stand? If you have a Women Veterans Committee, thank you. Look at that. That's great. There's more. If you would like to build a network of women veterans in your area so you can keep each other and DAV informed on key issues, please speak to your department commander. If you have any questions about how to begin a Women Veterans Committee in your state, please seek out one of these advisors or anybody from the interim committee, and they'll be able to assist you. If you have a special Women Veterans event and would like to request copies of our latest Women Veterans Report to share, please send an email to legislativepublic@dav.org and include the date of the event, the number of reports you're requesting, and your contact information. The only thing we would request is that you share your pictures of the event and include pics of the report on social, and now jot this down, social@dav.org. That's difficult, right? Social@dav.org. Send your pictures in, and we would love to share them as they come in, maybe on social media, so keep a lookout. And if you are posting on social media, just tag us, #DAV, and we'd love to share them. I'd like to take a moment to recognize today's seminar sponsor, Otsuka Pharmaceuticals. Otsuka is a global company with a strong focus in the fields of neuroscience and nephrology, with a particular commitment to advancing mental health, especially women's health. In 2023, Otsuka expanded its mental health portfolio through the acquisition of Mindset, a company exploring the use of psychedelics to treat depression and other mental health conditions. This bold step underscores their dedication to pushing beyond traditional boundaries in search of effective treatments. DAV strongly supports research into psychedelic-assisted therapies as part of our broader commitment to innovative mental health solutions. How many people were in the psychedelic seminar? Awesome. So earlier today, as you know, we did host a roundtable discussion, and that also was sponsored by Otsuka, to explore the potential of these treatments in addressing PTSD, depression, and suicide risk among veterans. For 2 years now, Otsuka has grown our partnership in showing the mental health community that it's time to think outside the box when it comes to mental health. Veterans have told us loud and clear the status quo isn't working. We must destigmatize innovative, evidence-based therapies and listen. Because when it comes, that's right, that's okay, yes. There is no one-size-fits-all solution, right? I'd like to now introduce one of Otsuka's very own, Caroline Fisher O'Neill, who will talk more about this innovative company. Caroline, please. Let me give you her bio. How about you know who she is? She's a senior public affairs leader with over 20 years of experience at the intersection of government policy and biopharmaceutical industry. She currently serves as Senior Director of Alliance Development at Otsuka America Pharmaceuticals, where she leads a newly established function focused on building strategic partnerships that strengthen patient access, advance health equity, and shape public policy across multiple therapeutic areas. In this role, she develops innovative collaboration strategies with a wide range of stakeholders, including advocacy organizations like DAV, trade associations, and thought leaders to amplify and drive shared policy initiatives in the U.S. Caroline is a longtime yoga, meditation practitioner, teacher, aspiring fluent Spanish speaker, and lover of travel and adventure. She lives in Brooklyn, New York, yes, with her wife and 2 sons. Caroline, please.
Thank you, Naomi. Thank you, everybody. That is a big picture of me. It is me. It's just this is the version of me in my full glory of my silver now. That was halfway through. It's an honor to be here with you today in what is my second Disabled American Veterans Conference. And thank you, Naomi, for the warm introduction. I would like to thank you and thank all of the DAV staff for all the work that goes into running this incredible organization. It's incredibly impressive, and also all the work that goes into these conferences. And I just want to say thank you also to all of you for offering me just a little bit of your time to speak on behalf of Otsuka. As Naomi mentioned, Otsuka's recent acquisition of Mindset is us entering into a very exciting new chapter, one that holds promises for veterans and others who have not yet found relief in their mental health journey. Through the research of synthetic psilocybin, I saw a lot of hands go up for the last session, so I'm glad you were able to attend. We hope to discover treatments for an array of mental health diagnoses. At Otsuka, we are deeply committed to mental health, and that commitment is rooted in respect for every individual, and especially for those who have served. We believe the human mind is infinitely valuable. It carries our memories, our resilience, our imagination. And for many veterans, it carries the weight of experiences that are hard to put into words. That is why we will not rest until mental illnesses and brain diseases are treated with the same urgency and priority as physical health. For over 40 years, Otsuka has worked to serve those with unmet medical needs, including people living with major depressive disorder, bipolar disorder, and schizophrenia. But we know that treatment alone is not enough. So here's a little more information about Otsuka. We are committed to changing the conversation around mental health by helping to remove stigma and discrimination through initiatives like Society of Valued Minds and our recent partnership on WIDA's caregiving documentary. We are also committed to addressing the needs of caregivers. Otsuka recognizes the critical role of family caregivers, many of whom are veterans themselves or care for veterans. Research that we sponsored with Columbia University recently found that caregiving-induced declines in health contribute to over $28 billion annually to healthcare costs. That's not just a number. It's a reflection of the emotional, physical, and financial toll that caregiving can take. And lastly, I want to mention our commitment to expanding access to care, especially in underserved communities. Through collaborations like the one we embarked upon with Meharry Medical College research team, we explored the economic burden of mental health inequities. That research showed us that the U.S. currently spends, this is quite staggering, an estimated $477 billion annually in avoidable costs related to mental health inequities and the impact or correlation that has with chronic physical health conditions. So I just want to point out to you today that research is very relevant to the panel discussion today, as it looks directly at how poor mental health outcomes are a significant risk factor in cardiovascular disease. At Otsuka, we see you. We see the strength it takes to carry invisible wounds. We see the families who stand beside you. And we are committed to being a part of the solution through science, advocacy, and compassion. Thank you for your service, and thank you so much for allowing us to be a part of this important conversation.
Thank you, Caroline, so much for the work that you're doing, and please know that we will continue to do our part to ensure women veterans have access to treatments that have the potential to save their lives. Our planning for today's program began the moment we stepped off stage last year in Phoenix. We left that event with a renewed focus on women veterans' mental health, recognizing the unique challenges we face and knowing we had only just begun to scratch the surface. At DAV's Washington, D.C. headquarters, we work closely with the Department of Veterans Affairs, particularly through our quarterly meetings with the Office of Mental Health and the Office of Suicide Prevention. The teams there are phenomenal, always responsive, always ready to collaborate, and one person consistently steps up and says, "What do you need? How can I help?" It's my pleasure to introduce Dr. Ilse Wiekers. Ilse Wiekers serves as the Deputy Executive Director in VHA Office of Mental Health, and in this role, she leads the operations of the Office of Mental Health and the timely development and implementation of policies and programs that ensure veteran-centered, evidence-based, and high-quality mental health services to over 2 million veterans every year. She leads OMH's legislative policy and partnership work, engaging regularly with key congressional and veteran service organization stakeholders. She has been instrumental in the development of VHA's portfolio of innovative mental health treatments, including ketamine, esketamine, and psychedelic-assisted therapy. Dr. Wiekers is a practicing board-certified adult and geriatric psychiatrist who completed her medical education at Duke University residency at MGH McLean Hospitals and fellowship at Yale. She received a master's degree in public policy from Duke University and a master's degree in health science from Yale University. I only bring y'all the best. Dr. Wiekers serves as faculty at University of California, San Francisco, and Yale. And she really, honestly, in her bio, should add here that she has a doctorate in, what is it now, Naomi? I'm just kidding. Please join me in welcoming Dr. Wiekers.
Thank you, Naomi, for that very generous introduction. Oh, and that's me. Like you, it feels really weird to see my head that big on a screen in front of so many people. I am delighted to be here. And yes, when Naomi called and said, Dr. Ilse, can I get you to Vegas for our convention so you can talk to folks about whole health and mental health for our women's seminar? I was like, absolutely, sign me up. So I am going to spend a little bit of time talking to you about how we've been integrating whole health into mental health and how that impacts women's mental health and some of the resources we have available for women, women veterans at the Department of Veterans Affairs. So I'm going to start, bear with me folks, by playing a video.
Even though that we served as well as men and we want to be looked at equally and the same, we are different. We have different challenges physically and mentally. There's just something different about the level of care that we need. When I go into the women's clinic, I'm there because I'm a woman veteran and they treat me as such. So to walk in somewhere where you feel comfortable with other people who have similar experiences just because they are women, it takes a lot of that anxiety and anxiousness away.
So I ended up getting another female doctor, and it took a little while, but I finally opened up to her and somebody could hear me for once, and I could just let go. And I went in there and I just screamed and yelled and cried, and I didn't even know what half of what I said was or why I said it. I just got it out, and she let me cry. This was a release and there was no judgment, and she wasn't trying to fix me, she was just listening to me.
The group was a support group, and it was really cool because we all felt empowered because there was other women like us that had experienced the same thing. There's other people involved, and instead of just having a one-on-one with the therapist, usually when you're having a one-on-one with a therapist, you're getting a professional person's input on how to do things. In group, you have other people that may think a little bit different than you and give you some advice, but it's also somebody who's been through what you've been through, so it comes from a different point of view. And it's like safety in numbers, so to speak, and we're developing relationships, that we haven't had before, of other people that you can identify with.
You have to be more responsible for your own care, and then try again.
With therapy, I was able to not only find my true self, but also find my true happiness. Now I'm a good mom, and I'm a good wife, and I'm a good friend.
So I am going to share with you a case of a woman veteran who's been receiving treatment at VA. Her name is Camilla, and she came to her primary care doctor saying, I will speak louder. Okay. Thank you. So I'm sharing with you Camilla's case. She came into her primary care and said, I just don't feel good anymore, and all I do is work. She's a 48-year-old Navy veteran and has reported to her doctor some changes this past year in the frequency of her menstrual cycle. Things are getting a little wonky. Onset of difficulty with sleep, fatigue, increased anxiety that she's experiencing, and feeling kind of down. Things just aren't going the way they used to go, and things have gotten more difficult. And her chronic low back pain has been getting worse over the last 3 months. She works as an outpatient medical clinic manager, and she endorses a significant amount of stress in her life. She has healthy relationships, but has limited social interaction because so much of her time is spent either working or taking care of her aging parents. She does have an adult child, but they live several states away, so they're not nearby regularly. No history of any kind of risk of harm to herself or to others, and the referral is placed for mental health, and it says perimenopause, degenerative disc disease, stable per imaging, depressive disorder due to a medical condition, refer to mental health. Raise your hand if something in Camilla's story resonates with you. Yeah, as a 48-year-old myself, yeah, right? So what is whole health in VA? I understand you've been talking about whole health at the conference. What does it mean from where I stand and the work that I do for the Office of Mental Health? I think it's really important that whole health is a way of being. It's an approach. It's not a thing or a singular kind of piece or a singular resource. It's just a whole ethos. And it's turning and flipping the script. So instead of saying, what's the matter with you? It's saying what matters most to you. Puts you at the center of your healthcare and your well-being. It empowers and it equips veterans to take charge of their own health and well-being. And this is what whole health is. It is kind of beyond just individual resources. It is not dependent upon resources because, again, it's a way of thinking about things. It's about turning the narrative towards focusing on you at the center, connecting with the mission, the aspiration, and the purpose of each individual veteran in charting their journey through life, which includes trying to achieve better health and well-being. It includes some complementary and approaches, but it also includes conventional, kind of standard treatment approaches. It's bringing it all together in a way that is most meaningful for that individual in the room. The circle of health components of health and well-being are very proactive. Again, you are at the center, right? Whole health is about you. You have the power when you are at the center of your health and well-being journey. And you are not alone, though, because as you see in the circles of health, we have community, and we have family and providers and neighbors and the whole community of other women veterans and other veterans that are there to help and support your journey. And change is possible. Change is possible. It can be hard, but change is possible. And one of the things that helps make change more possible is by allowing you to decide what we're going to work on next, right? So empowering you to say, of all of the things going on in my life, some of which maybe I cannot control, what are some things that I can control, and what are the steps I want to take to control them? And how am I going to find my way to better health and well-being? So, the conversation back to Camilla. Having a conversation and asking these types of questions help us to get to the core of what matters most for Camilla. When her primary care provider asked her those questions, this is what Camilla said. She said, I need to be able to help others at work, my family. That's what's really important. That's what gives her purpose, and that's what is meaningful for her. But there's a lot I want to do, and honestly, I've worked so hard all my life, I'd kind of like to have the time and energy to do something just for the enjoyment of it. Oh my gosh, can you even imagine, right? This is what matters most to her. So it's important to continue to put helping others first and empowering her so she can continue to do that important work that brings her meaning, but also helping her to prioritize herself a little bit too, so that she can do something and enjoy it. And so she wants to prioritize things so that she's not as tired all of the time. So this is what the conversation was like with Camilla. Women's mental health at VA is a fantastic resource, and women veterans have access to all of the continuum of care resources that every veteran does. This triangle, or pyramid actually is probably the better way of putting it, this pyramid shows the different levels of care that we offer at VA, from the very kind of base of integrating mental health into our primary care settings, all the way up into our specialty mental health services, our residential treatment programs, and at the top, the most intense type of treatment that we offer, the inpatient. But if you look at the bottom of that, the foundation of our mental health care continuum is this whole health system of care, the approach of trying to put veterans at the center and identifying what matters most to them. And women veterans, again, can have access to all of this, and it's important that folks know about the services that they can access and how to access them. So I'm going to tell you a little bit more about how and what it means to actually integrate whole health into our mental health. It's about, like I said earlier, it's an approach, it's a way of thinking about things. It's just how we do it now at VA. It's empowering veterans and connecting them with what matters most. It's using that as the guide point and the beginning for the discussion about care. And we equip veterans to use and access all of the range of resources that we have available, including some of our whole health resources, as well as our mental health resources. One of the things I want to emphasize about integrating whole health into mental health is that it allows our clinicians, our mental health providers across the continuum to really think closely together with each of those veterans as they're having those interactions in the office about partnering together. Because with the veteran at the center, partnered with their provider, partnered with family and community around them, they can move towards health and well-being. And I didn't realize this slide was going to make me click through the whole thing. Sorry while I get it all up there for you. So in terms of practicing whole health approaches in mental health care, we have practice across teams and over time. So this is more about kind of turning things and thinking about it as being on a journey rather than each episode of care or each interaction being focused on what's the symptom or what's the disease that we're managing. It's more about the larger and holistic approach over time and that relationship with that individual veteran. It's about learning how to practice self-care for the veteran and also for the providers, because we as a whole health system at VA, our providers are also practicing health. We have employee whole health for our providers and for our staff so that we can also take care of ourselves so that we can continue to take care of you. Because if we can't take care of ourselves, we can't take care of others. It is about continuing to provide excellent clinical care, high quality evidence-based care, but it's also about being aspirational, not just in the care that the veteran is seeking, but also as a system, trying to identify new ways of providing treatment and ensuring that we have the research and the evidence to show that they can help. And why is it so important to think about women's mental health? Well, because of all of you, because you are important, and because there's so many more of you now than there were 20 years ago. Look at these numbers. We have grown from only 160,000 women veterans using the Veterans Health Administration back in 2001 to over 600,000 today. That's an enormous amount of growth. %11 of all veterans who use the Veterans Health Administration are women. 40% of women veterans are reproductive age. 45% are in midlife. And almost half of women veterans enrolled in VHA are using VA mental health services. This is why it's so important that we focus and acknowledge what's important for women and women veterans. Our women's mental health resources are robust. We have mental health providers who have access to education and training that is supported through my office and my team on women's mental health. We have an expert consultation service as well, so that the National Reproductive Mental Health Consult Program offers consultation to providers across the nation and helps to address questions about reproductive mental health, which includes things related to menstrual cycle, things related to pregnancy, postpartum period, as well as perimenopause and menopause, the whole reproductive life cycle, so to speak. All of our VA medical centers have women's mental health champions at each of the facilities, and they are there to help support the needs of women veterans. And VA is strategically expanding our peer support services for women's veterans, and really enhancing that connection and trust and engagement so that we can see those numbers of women veterans using VHA go up and up and up. So let's go back to Camilla's journey. She was connected with her local VA Women's Mental Health champion, and they explored some of what Camilla had expressed as concern, which was how difficult it was because of her fatigue and her low energy, and that she wasn't able to meet the goals that bring her meaning and purpose, which are helping others, and she doesn't have that energy to do the things for herself and things that she enjoys. So she was surprised, actually, to realize and learn when speaking with the Women's Mental Health Champion how much perimenopause could actually be impacting her mental health. The risk of depression more than doubles during perimenopause. I'm going to say that again. The risk of depression more than doubles during perimenopause. And perimenopause can be like a decade of our lives. Ladies, we need to pay more attention to this, all of us, because this is important. Medical illnesses can change as we reach midlife. Physical activity can change during midlife. Hormone flux and fluctuations, hot flashes, sleep disturbance. Tell me if you've slept through the night and you're in perimenopause, because I haven't for 8 years, okay? Individual and cultural attitudes about aging have changed and are worth thinking about and noting and paying attention to. And then that doesn't even begin to deal with midlife stressors. Sandwiched between our kids and our parents, goodness, what are we doing? And we have a lot of loss and a lot of role transitions. And we sometimes gloss over that role transitions that come in midlife have profound impact on how we view ourselves and how we interact with those around us in our community and in our family and with our friends. These are all the sorts of things we should be thinking and talking about when we are engaging with our women veterans in the care that they receive at VA. So back to Camilla's VA mental health journey. She decided, in talking with the Women's Mental Health Champion, that interpersonal psychotherapy for reproductive mental health was a good fit for her. It was consistent with her desire to improve her mood and anxiety and to enhance her interpersonal relationships amid these transitions that she was experiencing in midlife, including the caregiving demands and the increased work responsibilities that she has. Her primary care provider reached out to that reproductive mental health consultation program for guidance on some of the most effective medications that might help address some of the depression and anxiety that she was experiencing, and the most effective way to really address how some of the hormone fluctuations were impacting her life in perimenopause. And she was also interested to learn more and to get some more information about the whole range of whole health options available to help address her back pain so that she could improve her physical wellness as well. I'm going to wrap up now by the video you saw at the beginning was from our Make the Connection campaign. And I want to make sure that everyone leaves today knowing how to access more information about women's veterans health care at VA, and specifically about women's mental health. So the Office of Mental Health has a year-round, 365 days of the year, education and awareness campaign that really focuses on reducing stigma associated with mental health conditions and increasing mental health literacy and helping veterans connect to the services and the care that they need. And you can find all of this and more at mentalhealth.va.gov. So please check out that website if you've not been there before. And in particular, the Make the Connection campaign includes thousands of videos featuring veterans just like you talking about their experiences, the challenges that they faced, and how they've reached out for support and mental health care and how that has helped. So whatever variation on the theme you may have questions in your brain about, we've got a video of a veteran talking about it. because we have worked tirelessly with our team to get out there and have those conversations and hear directly from veterans about how mental health services have helped change their lives. So if you've got questions, I'd encourage you to go to maketheconnection.net and watch a few videos. You can search by whatever search term you want and find a video that'll address whatever your curiosity may be. Because we are committed to reaching veterans where they are and helping them seek the care that they need and so rightly deserve. I was going to play a second video for you, but that is too much to ask of the video playing gods. Since we got the first one to work, we're going to take that as our success. And I am going to wrap up with that. I thank you for your attention. I thank you for your service. And it has been a pleasure to be here with you today. So I am going to turn it back over to Naomi.
Thank you, Dr. Ilsa. I told you guys, I bring you the best. Now, remember when I mentioned this journey started last year? There's one critical issue that we knew we had to address more directly. The #1 cause of death in women veterans, heart disease. We cannot talk about whole health without talking about heart health. And if you attended yesterday's whole health workshop, you experienced VA's whole health model firsthand, along with a powerful moment of mindfulness and meditation. If you were able to stay to the end of that workshop, it was fantastic. It was amazing. Thank you. Yeah, she did a great job. Our next speaker brings it all together. So, we talked yesterday about the whole health model and about mindfulness and healthcare, and then you just heard Dr. Ilsa talk about mental health and how that plays into whole health. And so we're going to talk now about heart health and how they're deeply connected with it all. Dr. Elizabeth Lay is a staff cardiologist and director of the Echo Lab at the VA Portland Healthcare System, where she has served since 2008. She is also an associate professor of medicine at Oregon Health and Science University. Dr. Lay earned her medical degree from Yale, trained in internal medicine at Yale, New Haven, and completed her fellowship in cardiovascular medicine at the University of Virginia. She is also a fellow of the American College of Cardiology, the American Society of Echocardiography, and the American Heart Association. Dr. Elizabeth Lay is not only a leader in her field, she is deeply passionate about caring for general cardiology patients with a special focus on heart disease in women. Please join me in welcoming Dr. Elizabeth Lay.
I'm vertically challenged. Sorry. Thank you, Ms. Mathis, for the kind introduction, and thank you for the invitation from the organizing committee to be with you here today. It is an honor because when I was in medical school, one of my very first veteran patients was a nurse from World War I. It was an amazing experience, and I just love taking care of veterans. That's why I chose to work at the VA. Before I start, though, I want to say thank you to all the veterans for your service, especially to the Vietnam veterans. And the reason for that is because of your collective sacrifice, I'm able to stand before you here today. I arrived in this country 50 years ago as a Vietnamese refugee. You took care of our family to get us out of the country, and you took care of us when we landed at Camp Pendleton. So with that, I am eternally grateful. All right, so on to the important topic of heart disease in women. I have no disclosures, and I need to tell you that the contents do not represent the views of the VA or the US government. So as far as heart disease in women, we have different buckets of heart disease. So I want to define them for you here in the beginning, but the predominant topic today would be coronary artery disease. So when I think about the heart, I think about it like a house. So a house has rooms. So those are the 4 chambers of your heart. The house has doors, so those are your valves. So you have 4 valves between the different rooms and the big artery and vein that comes to the heart and go away from the heart. And then you have the plumbing system. So that is your coronary arteries, and those are the pipes that get into trouble when it gets built up of cholesterol. And then, of course, the house needs an electrical system, so those are the electrical wiring that can go haywire as you age, and then you would need interventions. So as far as heart failure is a problem predominantly of the muscle. There can be many reasons for that, but we see a lot of the heart muscle becoming weak, so the left bottom chamber, called the left ventricle, does the major pumping throughout your body. But interestingly, in women, heart failure, half of the time, it's because the heart muscle, even though it can pump normally, it doesn't relax normally. So the heart muscle can get thickened over the years as you have high blood pressure, but you don't know about it. So that also results in heart failure. And basically, heart failure, the bigger picture is that you have too much fluid in your body and you need to be on a water pill so that your kidneys can make urine, and then you can get rid of the extra fluid so you don't get short of breath. Next is heart valve disease. So we have 4 valves, but the 2 most important ones are the aortic valve and the mitral valve. The aortic valve is the most important one, I think, and it is between your left lower chamber, which is the left ventricle, and the aorta, which is the big artery that sends blood to the rest of your body. As you age, that valve can get calcium deposit on it. So then think of it as a door that can't close completely and can't open completely. So as we get older, women tend to have trouble with calcium deposits, so they have a condition called aortic stenosis. And many of you may have heard about this, not so new anymore, but the procedure to treat the aortic stenosis with a new valve that goes through the leg instead of open heart surgery. For women, we don't get referred to as often as men because we tend to have a smaller valve. But that shouldn't be the case because of a recent study in Europe that showed that women do just as well as long as they get referred for the procedure. The mitral valve is the other valve that can get calcium on it, but in the US, we tend not to have that problem, but we get calcium deposit around the valve, so around the frame of the door, and that can be very difficult to treat. For the same reason, that valve can not close completely, so you get a leaky valve, and that can necessitate you having to be on a water pill or getting the valve replaced. The abnormal heart rhythms has a big range from being too slow and to being too fast. So in cardiology, we are very simplistic. If it's too slow, make it faster. If it's too fast, make it slower. And we do that using medicines or intervention procedures where we can go in and burn the extra electrical wire. And then the last big group of heart disease is pericardial, and that's just a fancy word for the lining around the heart. So the lining can get calcified, so then your heart can't relax easily, or you can get inflammation. The aorta is that big artery that goes from the heart to the rest of your body, and it can get bigger over time, especially in some patients who have had high blood pressure that you don't know about, and that can cause the aortic valve to be leaky. Okay, so why should we care about heart disease in women veterans? Over the last 30 to 40 years, we've made so much progress in terms of treating heart disease and women have benefited, but not as much as in the veteran population as the civilian population. So this is a graph that shows the number of deaths from heart disease from 2000 to 2016. Women veterans are seen in the blue line, and you can see that although there was a rise up to about 2005, there was a decline from 2005 until about 2011. And at that time, the death rate continued to reverse itself and increase. So overall, during that period of time, there was about 6% increase death rate. That is in opposition to the female civilians who, as you can see, enjoyed a decline from 2000 to 2016, that overall their decline was about 17%. And that shouldn't be. Women veterans should have similar or even better outcomes than the civilian women. So what do we need to do? We need to educate you, we need to educate providers about the cardiovascular risk factors. And they can be grouped into 4 big buckets. There are the traditional risk factors, which I learned in medical school a very long time ago. But in the last 10 to 20 years, we know about the female-specific risk enhancers, and then over the last 5 years, we are now paying more attention to pregnancy-associated risk. And then finally, the military service. There are some risks that are associated that are not discussed very often during the clinical visits. So I'll go into detail in each of these groups. Okay, so the basic traditional risk factors. So the American Heart Association updated their risk life essential 8 about 2 years ago, and we all know that nutrition is important. So you need to eat more fruits and vegetables and avoid processed foods, okay? As far as physical activity, the recommendation is at least 150 minutes of moderate intensity exercise per week. The more, the better. But basically, you should strive for 30 minutes every day. And you may have heard about taking 10,000 steps a day. And more recent data have shown that you don't really need the 10,000, and that about 8,000 will do, but you need to walk at a certain cadence. So just remember, 88 steps per minute, about 8,000 steps a day. So for people who are active, it's actually difficult to get that number unless you have dedicated time to exercise. Blood glucose. That is a silent condition, prediabetes, that you don't know about unless you get screened. It doesn't jump out at you. You won't have any warning signs until it's too late. And patients can have prediabetes for 10 to 20 years without knowing it. And by the time you have frank diabetes, the cat's already out of the bag. In terms of weight management, that is also a lifelong behavior that we all need to work on, because we know that as we get older, it's harder to get the weight off. Okay? Blood cholesterol is the same. Unless you get screened, you won't know about it. And the percentage of people with familial hypercholesterolemia, where there's a genetic disposition, is actually pretty high. So if you don't get screened, again, we can't intervene. And cholesterol buildup actually starts during your teenage years. And we know that from a really old study of veterans. These men had died in their 20s, and they had autopsies done, and they already saw cholesterol deposits in their arteries, okay? Blood pressure. Blood pressure is probably the most significant silent killer. And again, having high blood pressure doesn't hurt. It's not like having a cut where you see yourself bleeding and you're going to do something about it. Unless you get screened, you won't know until it's too late. And often patients present with a heart attack or a stroke when they have high blood pressure that's untreated. Nicotine exposure, I don't have to say much, just don't do it. And then recently, with this new update from Life Essential 7 to 8, we are recognizing that sleep health is very important. A lot of us don't get enough sleep, and then when we do get sleep, it's not the good kind of sleep where the recommendation is 7 to 9 hours per night. Okay, nutrition. So what should we be eating? Ideally, we should be eating fresh fruits and vegetables, nuts, whole grains, and lean protein. If you can't get access to fresh fruit and vegetables, frozen is the best because the companies just flash freeze the product and there's no salt. So essentially avoid anything that's in a can. Okay. Some patients will tell me, but I rinsed the green beans out. It's too late. The salt is already embedded in the green beans, and even though you rinse well, it's there already. You can adopt the Mediterranean diet, which advises more servings of fish and olive oil. If you're a vegetarian, that's great. That's perfect because cholesterol is actually only in animal products, okay? And then the DASH diet, those are for patients with high blood pressure. So ideally, the recommendation is to only consume or eat 15 milligrams of salt or sodium per day. The average American diet has 4,500 milligrams a day. So that's very hard. If you go from 4,500 to 15, the food is going to taste bad and you won't stick with it. So you have to do it gradually. So I tell my patients, don't eat anything from a can. Don't eat anything that is frozen prepared like Stouffer's lasagna. And you have to start reading the labels. And here, the companies can mislead us because they would, for example, in a can of soup, it will be 3 servings. So 200 milligrams per serving, and most of us can eat a whole can of soup, actually, for lunch. So that is actually 600, and that is like more than a third of your allotment for the day. And if you do this over time, so over a couple of months, your palate will adjust so that when you go back to eating salty foods, it will taste bad because it's so salty. And then if you want to know what is the best fruit and vegetable to eat, look at the panel on the right. So eat fruits and vegetables with a lot of color, okay? The more color, the more vitamins, the more nutrients, the more antioxidant that's going to be good for you. Okay, so blood glucose. Unfortunately, with diabetes, it affects women more than men, and we don't understand why. When women get diabetes, they have 4 times higher risk of developing heart disease in the future compared to only 2 times in men. And women who have diabetes and smoke, the risk is actually exponential. It's not linear. So don't mix the two at all, and it's best not to have either. Sugar. So sugar in our food is the main culprit. On average, the American diet has 17 teaspoons of sugar per day. If you drink a can of soda, regular soda, there's 10 teaspoons of sugar in that can. So the carbohydrates will add weight, and it will increase your risk of having diabetes, which in turn will increase your risk of heart disease and stroke. Weight management. So this actually parallels the diabetic rate in the US. On the top left is a map of the US, and it's color-coded by the percentage of of the population that is diagnosed with obesity. You can see that about a third of the states are in the peach color, and that's about 30%. So at that time, we have probably less than a third that's green, that's about 20 to 25%, and the majority it's yellow. Fast forward to 2024, there's hardly any yellow or green states. And there are 3 states that's in the burgundy, and that is 45 to 50% obesity of the population. Okay? And we know that this tracks with diabetes. So what can you do? You can stay active, exercise, and watch your diet. Okay? I want to give you this example to point out that it's not only the choices that you make when you eat, but it's also the portion size that's important in terms of calorie intake. So 20 years ago, the average bagel was 3 inches in diameter, and if you eat the whole thing without anything in between, so no cream cheese, nothing else, it's about 140 calories. How many calories do you think the current bagel has? Pretty close. So nowadays, the average bagel is 6 inches in diameter, so twice the size, with an addition of 210 calories, so that's about 350. Okay? And in terms of weight loss, it's very simple. It's really calories in versus equals calories out. So based on a 130-pound person, how long do you think it will take you, let's say, raking leaves to burn that extra 210 calories? And remember, if you consume 3,500 calories, that's equivalent to a pound. That's going to take a long time. So 50 minutes. So I don't enjoy raking, and I'm sure you have better things to do. So think next time when you eat an extra 200 calories, think of all the fun things that you could be doing, okay? And it's a daily thing, right? You can say, oh, it's only 200 today, I'll be better tomorrow. It doesn't happen. You have to be good in terms of your diet. And it's hard. Lifestyle change is hard. Okay, cholesterol. So there are many different cholesterols out there, but the one that we pay the most attention to is the LDL, or quote unquote, the bad cholesterol. And as mentioned, the cholesterol starts to build up in the arteries. And in women, the buildup is not like in men. Men tend to have a single blockage or a single narrowing that is easier to treat by putting in a stent that can open up the artery. Women tend to have more diffuse cholesterol buildup, so it's not easy to put in a stent. And women tend to have smaller arteries than men, so that makes it harder too. Compared to men, when women start to gradually have blockages in their arteries, they can have chest pain, but not always. And I have a slide at the end to talk more about the symptoms. But for some reason in women, especially if they smoke or if they have diabetes, the cholesterol can rupture. So think of it like a volcano that erupts. So you shear off the top part, and now you expose all the bad stuff in the cholesterol plaque. So then your blood tends to like to form a big blood clot and cause a big heart attack. So again, with cholesterol, if you don't check, you won't know. So in general, I advise my patients to aim for an LDL cholesterol of less than 100, but that also depends on how many risk factors they have. And in patients who have had diabetes or have had a heart attack or stent or open heart bypass surgery, that number goes down to less than 70. And then in patients with really high risk, we are now starting to recommend less than 55. So again, unless you check, you won't know. And then we have a lot of good medicines available now to help you lower the cholesterol. Okay, so blood pressure, again, you gotta know your numbers. Ideally, it should be less than 120/80. The top number is the systolic number. The bottom is the diastolic. And as we age, we tend to have a higher systolic number. And as you can see, there are different ranges of hypertension. And once it gets over 140/90, most of the time patients will need to be on at least one medicine to help lower it. Okay? nicotine, cigarettes are bad for you, vaping is bad for you. Essentially, that's the bottom line. So sleep health, I mentioned that we now are becoming more aware that sleep health plays an important role in the development of heart disease in the future. So aim for 7 to 9 hours at night. We know that when you don't get good sleep, you tend to have also memory problems, and it can make your other medical conditions worse. Okay, so moving on to the sex-specific risk factors. Depression is high on the list, so we had talked about that during the last talk. The age of when women have their first period has now been shown to have an important be an important risk factor as well, and also if you have had polycystic ovarian syndrome. Okay. And then the other two sex-specific risk factors, women more than men tend to be diagnosed with lupus and rheumatoid arthritis. Those two conditions also increase your risk of having coronary artery disease down the road because of the inflammation. Okay? So if you see a rheumatologist, usually for these two conditions, make sure that they are aware that these two conditions are linked to heart disease. As far as pregnancy, adverse pregnancy outcomes, we used to think that if you had high blood pressure, preeclampsia, gestational diabetes, once you were done with the pregnancy, you deliver your baby, that you didn't have to think about it anymore. But we were wrong. So we know that these conditions also increase your risk down the road. And also important is if you had a preterm delivery, if your baby was too small or too big for the gestational age when the baby was born, and if you've had trouble with the placenta during pregnancy. So most of childbearing women have received their care at the obstetrician, right? So they may not concentrate so much on these risk factors down the road. So please bring it to their attention, especially if you've had it. We usually recommend that within the first 6 to 12 weeks that you see somebody to specifically address these risks. So if you have not had your you should have had your blood pressure checked during pregnancy, but your cholesterol, your sugar, all that should be checked. And then as we move on to late adulthood, if you have had premature ovarian failure or premature menopause, that also increases your risk of heart disease. And there was a recent study that some women veterans who were exposed to combat, they are experiencing premature menopause. We talked about the lupus and the rheumatoid arthritis already, but I also want to mention breast cancer. So for women who have had breast cancer and who have had chest wall radiation, that also increases your risk because we know that the radiation builds up calcium around the opening of your arteries. So 10, 20 years down the road, they can have narrowing of their arteries and reduced blood flow, and they can have chest pain and a heart attack. So the military-specific risk. So we now know, based on a lot of data, that post-traumatic stress syndrome and depression and housing insecurity, all those risks increases a woman's chance of developing heart disease. And I included housing insecurity because we know that women veterans more than male veterans experience housing insecurity. So if you have these conditions, make sure that your providers know about it, okay? Because we usually don't have time as a cardiologist to bring these topics up, but you can advocate for yourself, bring it to our attention. So, with these conditions, I may not have time, but I will ask my patients, can I refer you to a mental health provider? Because it's so important that we work together to treat heart disease. Stress. So I don't need to tell you much about stress. Chronic stress are experienced more in women than in men, and they can lead to unhealthy behaviors, right? So we need you to try to find ways to cope with stress. So again, let your providers know so that you can be referred appropriately. Make time to do activities that you enjoy. Hang out with your friends and your family, your supporters, and try not to be engaged in activities that upset you. And the one thing that I found out, because I have some patients who watch the news, and they are so irritated, and I ask them, why do you keep watching the news? It's going to drive you nuts. The one thing I want to mention about stress is, as mentioned before, women do not take care of themselves. They spend time taking care of their husbands, their families first. And if you don't take care of yourself, you can't take care of them, okay? And for my male patients, the patients who come with their wives, they have the best care. Because the wives are the one who take notes, who ask questions. The men would just tell me, I'm doing fine. And then the wife would chime in, and then the list starts. Okay, I want to let you know about the symptoms of a heart attack, okay? Because this is not like the classic teaching. Women patients don't come in complaining of chest pain. So they ignore their own symptoms, and the providers don't pay too much attention. But this is a great study. It's an old study, but it's still relevant. So they survey women about their symptoms weeks before their heart attack, and then at the time of their heart attack, okay? So as you can see, the least common warning symptom is chest pain before the heart attack. So 70% of women would just come in complaining of unusual fatigue. So they would say, I just can't do my household chores anymore. It takes me longer. And then, of course, we just say, oh, that's probably your age, or you're just working too hard, okay? Women will complain of sleep disturbance, of shortness of breath, indigestion, more anxiety, and only 30% will come in complaining of chest pain before the heart attack. At the time of the heart attack, the most common symptom is shortness of breath. Chest pain follows at about 57%, but some women will only complain of, again, just weakness, nonspecific, unusual fatigue, cold sweat, and dizziness. You know your body best. So if the provider's not willing to go further, speak up. Just say, please refer me to a cardiologist, or please do more testing. Just don't ignore it. Okay, so this slide is familiar. The left is the whole health principles, and it complements the way that we should be approaching the care of heart disease in women so well. So for every principle that you see on the left, that can be applied to all the risk factors to care for heart disease on the right. Okay? And then I want to make a pitch again to advocate for your own heart health. So an ounce of prevention is a pound of cure. So now that you are aware of the risk factors, if your providers don't bring it up, you bring it up, okay? And I know that some veterans choose to get their heart care outside of the VA, so some of those providers may not be aware of the military-associated risk. And this is an infographic from the American College of Cardiology educational program, and even they recognize that being in the military is associated with higher risk than in civilian women. Okay, so that is all that I have, so thank you so much for your attention.
That was really good. Eat your cake and have fun. Come on. Gotta watch out for your heart. All right, so we do have a little bit of time for some Q&A. So if you come up to the mic, you have any questions for our presenters. Now, I have some ground rules. Keep your questions to less than a minute. And do not give out any personal health information. And make it fun. All right, go.
Hello. Hi. Sorry, I'm vertically challenged as well. Hi. Barbara Stark, Portsmouth Federal Chapter 22 in Portsmouth, Virginia. Hey. I would just like to know if these presentations can be made available later to us. I know I have a couple of female veterans back in my chapter that would absolutely love to have this information.
I'm so glad you asked. Also, let me just say, with everybody that's leaving, real quick, we do have some handouts in the back. That's number one. And number two, we are going to have some swag bags. And y'all know I've got some good swag bags. So, yes, the slides will be available. And I encourage you to take a look at them. They'll be on dav.org and they'll be on the convention page, is what I'm being told. So, yes, they will be available. All right, next question.
Hello, Corinne Myron. I had a two-part question. One is the VA looking into more holistic treatments also for any of these issues?
So you're talking about like alternative therapies, like yoga and stuff like that. So if you were at the Women Veterans Workshop yesterday, they actually do offer that as a as part of the whole health model. Yoga, Tai Chi. We found out they do clinical hypnosis. Yes. So the answer to that, and I don't want to speak for VA, but the answer to that is yes. If you go on VA's website, and I think it's va.wholehealth, I think is what she's, or wholehealth.va.gov, or so. Listen, if you go on the VA's website and type in whole health, you'll find it.
Okay. Second part, only because I've known other veterans that had this issue, being women, when they asked to see a cardiologist, you're instead said it's all in your head and referred to mental health. How do we get around that as women?
Tony?
Hello, testing.
Okay, it's working.
Regarding the first question, at the Portland VA, we do offer the yoga and all that, but
Come up here.
so at the Portland VA, in terms of alternative therapy, we actually also offer acupuncture. So that's all available, and I actually do recommend to my patients these alternative therapy because it also serves as support groups. Okay. As far as providers not listening to you, just ask to be referred to cardiology. Okay, because the primary care providers are overwhelmed. They have such a large panel. We don't have as much of a large panel. So at least at the Portland VA, we don't turn away anyone. Okay.
Thank you. Next question?
Lori Dean, Chapter 39, Midwest City, Oklahoma. My question is, when you first said, write it down, that address, I missed getting that down, so could you repeat that for me?
When I said write down
Yes, it was, I think social at
social@dav.org.
Thank you.
No problem. Thank you for asking. Next question.
Hello,
Hi.
Andrew, Chapter 145, New York. So it's a two-part question for Dr. Lee. In regards to fasting, what's your opinion for your heart health on that? And the second question is, when it comes to eggs and cholesterol, because I've looked online, some people say it's good, some people say it's bad. So I just want to hear your opinion on it.
Those are great questions, by the way.
In terms of fasting cholesterol, we still get fasting because it can affect the triglycerides, which is another type of cholesterol. That is not as important if your facility measures the LDL cholesterol directly. If they use the old way, which is a calculation, having a triglyceride level above a 400 can affect the LDL. It makes it look better than it should. And triglycerides are high if you have a milkshake or eat a hamburger before you get your cholesterol. So for some of my patients, if they have an afternoon appointment, it's too much to ask for them to fast, then I tend to get it anyways, and it looks really good with them eating, then it would be better fasting. Okay. And what's your second question? Oh, eggs.
Yeah, the eggs.
Oh.
And if I may sneak one more question, it just came to mind, please. No? Okay. All right. They said no.
Eggs has about 300 milligrams of cholesterol. So if your diet doesn't have any other cholesterol component or saturated, you can eat eggs, but I would not eat an egg every day. Okay.
You can ask the next question.
Oh, the next question is, with exercise and diet, let's say you have, you mentioned the arteries and how with backed up plaque or cholesterol in it, can you reduce or get rid of that cholesterol with exercise and a good diet? Can it like go away completely?
Unfortunately not. So we don't have any medicine that's like Drano that can clear the arteries. Once it's there, what we can do, the best we can do is keep it from getting worse. But by exercising, you actually decrease the inflammation. So less likelihood that your cholesterol plaque will rupture like a volcano. So exercise is still good. So the prevention is the best medicine.
Okay, thank you.
Great questions, actually. Yes, thank you.
My name is Shanda, and first of all, I'd just like to say thank you so much for being here. Thank you so much for enlightening us on everything that's happening, and I am a true believer in VA research regarding its evidence base. So thank you, VA. My question is, are we simply assuming that trust is at the heart of the whole health concept? I would just like to hear your take on that and where you see trust playing a crucial role. Because it's one thing to address the case study and the boundaries and everything, but trust also ties into relieving anxiety. Do you know what I'm saying?
I hear you, yes.
Thank you.
So I think that establishing trust and finding a provider that you trust and who you feel like the connection is there and you hear them and they hear you, and it's because it's a two-way street when you're both working together to improve your health and well-being overall. So I think, yes, I think trust is a vital component of your care journey, and I think finding that provider that you trust will help improve your outcomes overall. And so sometimes that requires you to speak up for yourself and ask for maybe a new provider if the one that you're with isn't a good fit. And I think that is really important, not just in mental health, where we talk a lot about a good fit, right? We talk about the good fit between you and a therapist, but I think that's just as important sometimes with your cardiologist, with your primary care doctor, with your kidney doctor. It doesn't matter, but I think trust is important, yeah.
Yeah, I'm just asking as a former psychiatric nurse and registered counselor, because sometimes by the time the veteran arrives, they've already been through so much, and establishing that foundation is critical. So thank you for that.
Completely agree.
Next question. Do you need help? Do you need assistance?
Yes, Joanne Compton, Chapter 4, Maryland. For older veterans, when will your guidelines actually hit the care providers? Diabetes, A1C of 70, of a 7, is okay now, so they take insulin away. Mental health medication has black box warnings on them, so after you turn 55. Heart disease, when you hit after 70, it's all in your head. I would just like to know when all of this good stuff you've been talking about is actually going to be out there to help the veterans.
Anybody?
I appreciate your question. I think that we have a lot of great work happening at VA, and I know that the one thing that I know is that everyone who works at VA is there to serve veterans. That is the reason they're there. And so if you don't feel like you're getting the care that you need, keep fighting for yourself and asking for what you need. You've raised some good points. There's a lot of information out there that makes accessing that care for you challenging. And if you need to advocate for yourself so you get what you need, keep doing it. Okay?
You got a twofer. You got the other doctor coming up too.
You asked an excellent question. And the current data that we have for heart disease, for cholesterol, for diabetes, many of those research studies excluded elderly patients. So when we say elderly, I'm thinking 75, definitely 80s and 90s for sure. So that not having data makes us have to extrapolate. So use the data that we know. But the American College of Cardiology has recognized that, so there is a lot of interest in forming geriatrics cardiology interests. So we are working on that, and then I can also let you know that the VA specifically is working on the clinical guidelines for menopause, and that should be out in August of 2026. And that is sorely needed for primary care providers and for cardiology as well.
Hi, you can stay right there. You can stay right there. Don't go nowhere.
I just want to say one thing. Remember I told y'all, we want to normalize saying the word even, menopause, because it's so important. There is a large number of us that are in perimenopause and coming into full-blown menopause, and women veterans also tend to go through menopause at an earlier age than their civilian counterparts. So we want to, sort of normalize that, and I'm really happy to hear that VA is coming out with some things on that. Go ahead.
Okay, my question is for her while she's still standing up. What about the female has PCOS, heart disease, diabetes, obesity, major depression, like all the high cholesterol? What is your recommendation for them?
For a patient with so many risk factors and diagnosed disease, I would encourage you to see a cardiologist regularly. So if you haven't been referred, ask for that referral. And then your cardiologist, your primary care provider, should be working in conjunction with the mental health providers. Because
now, what about the person that's seeing everybody? That's how they're diagnosed, and they're seeing all the people that they're supposed to see. What is your personal recommendation?
I'm not sure I understand the question. What is my approach to caring for that patient? Okay, so usually I make sure that all the guideline targets are met in terms of blood pressure, diabetes, exercise, and all that. But I also always include the mental health providers and the primary care in my care plan and say, I need your help. I need you to refer this patient to a nutritionist to help with diabetes, because I don't have the staff to keep a close eye on the glucose, let's say, the sugar. And then I also make sure that the mental health providers see what I'm doing and say that, for example, I think our patient could use some different medicines to treat the depression. What do you think? What do you recommend? So it has to be a collaboration, and it has to be communication between all of your providers.
Okay.
Okay.
So, and I think that's the problem. I think at the VA, you might have all the consultations and all the providers, but they don't work together. And that's what need to be worked on at the VA.
Yeah.
One of the ladies walked by and she wanted me, that my second question is for someone else. She had walked by and she wanted to know, is there a correlation in COVID and heart disease?
Yes, there is. We know that patients who were acutely infected with COVID tend to have their right heart. So their right heart failure was seen definitely more often. And it causes just a lot of inflammation, the way that the body responded to the virus. So that makes the blood in your body more likely to clot. So we saw a lot more blood clots, and the blood clots went everywhere. There was higher risk of stroke, heart attacks, blood clots in the legs. So yes, there's definitely a link. And even after you recover from the COVID, the risk is still there 2 to 3 years afterwards. And we're trying to, we still need more time to see what the long-lasting effects are. But there was definitely a connection.
Well, that's not comforting. From someone that's had it twice and is a long hauler. Next question.
Hi. So I'm a service officer. One of the things we've been hearing a lot in the field is a lot of concern coming from all of the DEI rollbacks, especially with some of the more information that's come out over the last few weeks. Is there any concern that with those rollbacks that it could start impacting women's health care through the whole health program, or the whole health program as an entire entity?
That is a great question. Thank you for asking it. No. So I'll say a few more words than that, though. Whole health is still alive and well and strong within VA. The program office is still thriving and is not going anywhere. Women's Health Office and my division of women's mental health remain strong and thriving and are going nowhere. Okay.
Here you go. Next question.
Hi, first-time caller, long-time listener. Denise Chambers out of Chapter 11 in Springfield, Missouri. 2 questions. The first one is, can you speak on to what initiatives there are to try to sit there and increase the rate of, the speed of access to mental health care? Because it's, been very difficult, even coming out of support and then having to go back and say, hey, there's a new issue, I need more support. We're still looking, like in my region, the Fayetteville area, great people, but we're looking about 87 days is the average to see a mental health professional that can actually address the issues for you.
So in terms of accessing mental health care, a couple different ways that folks can go about doing that. One is with referral from primary care into a specialty mental health clinic. Some of those, depending on the type of mental health service or treatment that you're seeking, can have a longer wait time. Referral to community providers is offered as an option when there isn't availability inside VA system right away. There's also mental health care embedded into primary care, or PCMHI, primary care mental health integration. And so there are opportunities to get support and care right there in your primary care PAC team. And that mental health provider can also support your primary care doc so that they can actually help provide some of maybe the medication. But the issue about accessing therapists can be a challenge. And I'm really sorry to hear about the wait times you have in Fayetteville area. And know that we are working hard to recruit and to retain high quality mental health providers across the nation. I actually work with some of the mental health recruiters. We go to the major mental health professional society meetings and are there trying to recruit and bring more folks on board so that we can hopefully bring those wait times down. So,
thank you. And then my second question was on these alternative therapies, or I don't know, I guess the holistic aspect, like the yoga classes and things like that. Again, I mean, I get all my emails out of my healthcare system going, hey, come to Building X, we're doing yoga on Thursdays, and it's 97 miles away from me. My local CBOC is 4 miles away. Do you know if there's any initiatives to try to push things like those into the CBOC so that more veterans can access them?
That's a great question, and I'm actually going to have to go back to my colleagues at the Office of Whole Health and see what exactly they're doing in helping to reach out into some of the more CBOC locations. But I'll get back to you. Yeah, and
in our workshop yesterday, we learned that there's also a lot of videos online that you can sort of take a yoga class basically online in the meantime. And also, don't forget, you have to, the greasy wheel, wait, what?
Squeaky wheel.
Squeaky wheel. The squeaky wheel gets the grease.
There it is.
So be the squeaky wheel.
Yeah, yeah.
Next question, and we've got 3 minutes.
Okay, this is my question. Similar to, like, she was from Fayetteville. I'm from North Carolina in the Raleigh area. And it seems like all these things we say are out there, they're not available at every VA. Like in Raleigh, some of us go to the Durham VA, some go to Fort Liberty. So I have a friend at Fort Liberty who can get massage therapy. But the Durham VA, even with chronic joint pain, they will not authorize the massage therapy. So, and the question that was asked earlier about mental health, we have the yoga, the Tai Chi, all that kind of stuff through recreational therapy, but that's tied to going to mental health. So if you don't go to mental health, then you're not authorized to get those things. So, and it's like, and if you don't know somebody that tells you, it's like you gotta find out. So we need to make sure that all these things are more, people are more aware, put it out there, so female veterans will know, since we're in females right now, the things that they can get and ask for. Because if you don't know about yoga, how are you gonna know to ask? You know?
Yes, you're absolutely right. Thank you. And that is, again, something that we spoke on the presenter spoke on yesterday,
Yeah,
Jennifer Childers in the workshop, that they're trying to get it across, the VISNs and, better visibility. And that's something that we also advocate for when we're up on the Hill and we're talking to VA, that, it's not right that you have all of these, a plethora of services that are available in one area and not in the other, particularly when you talk about the rural areas. It's not right that just because I live in a rural area, I don't get the same care and the same treatment. But I will say that she mentioned, if you were there, you heard in the whole health model that they are trying to roll that out across the board and better.
But this is not rural areas. We're talking about Raleigh and Fayetteville.
Yep.
They're not rural areas.
Yeah, no, I understand.
Just that,
I understand. It's just geography, right? And it's not right. And also, you're also looking at as was mentioned, there might not be providers in that area. And when we talk about, so the massage therapy, that's also community care. And you really have to advocate for yourself, unfortunately, and tell them, this is what I need, I feel I need, this is what I think will help me. And you're not asking for a pill, right?
But the thing about it is like, it's only authorized if you have, say, like, what's the disease that you really, what you saying? Yeah, you gotta really have fibromyalgia, you gotta have whatever, you gotta be like, you know, really have something to get it at Durham VA, but in Fayetteville, arthritis, they can get it.
You can also email me nmathis@dav.org. You can send me an email if there is an inequity happening. Please feel free to email me, and I can take it up to other people to take a look at VA Central Office.
And before I sit down, the question that one of the females asked about, why do we have to go through mental health in order to get yoga and Tai Chi and all those other things? Why can't we just go because we need it, I want to go?
I'm pretty sure it was mentioned yesterday that you don't necessarily, I thought she said.
To a Durham VA. At Durham VA, for recreational therapy, as they call it, you have to go through mental health and get evaluated. And then the chair of
email me, send me an email, please.
And then they're going to stop it. Okay.
Yeah. Yes, send it to me and I will take it to Central Office. Yes, ma'am.
Hello, Tiffany.
And we're over time.
Okay, I will keep it real short. Tiffany from Wisconsin. This is for Dr. Lee. This question, it's about cardiovascular health and psychotropic medication. If you have seen an uptick, or if there's research out there about increase in like cholesterol, triglycerides, that kind of thing. Because I heard that there was a correlation between the two, and I just wanted to know what you know.
I am not aware of the psychedelics increasing.
Psychotropics.
Psychotropics, sorry. Adverse effects on the heart. But the one thing that I can comment on is because I'm from Oregon and cannabis has been recreationally used, I have a lot of patients who are on that for other ailments, and I have no trouble advocating and supporting their use, because if they have less pain, that will help with their blood pressure, their heart rate. So as far as we're concerned in Portland, the use of cannabis is acceptable as part of the therapeutic regimen.
Oh, thank you.
And I will add, there is association between a class of psychiatric meds known as atypical antipsychotics, so some of the newer agents used for antipsychotic treatments, with cardiometabolic risk factors, so weight gain, increased cholesterol. So those would be medications like Seroquel or Zyprexa. Tend to have weight gaining effects, and those cardiometabolic side effects need to be monitored. So part of, if that is a medication that you're prescribed and you need to be on, then that is actually part of your psychiatrist's monitoring of your ongoing health, is to be checking those labs once a year, just to make sure that they're following and making sure that it's not having a negative side effect.
Okay, thank you.
Yeah.
Last one.
All right, last one. I swear it's going to be quick. This is Tracy from Massachusetts, Chapter 47. So as a psychiatrist, I work at the VA as well, and I work in mental health. I'm really glad that there's a mental health professional and a cardiac professional up there, because as a person who's been going through CPT training, ACT training, all the things to help cope with my PTSD, the one thing that I haven't been able to get an answer from either one of you guys, from your departments, is all those symptoms that you said that could be risk factors and signs of me having a heart attack are also anxiety attacks. That you've taught me to do all these coping mechanisms for me to get over it so that I don't have false ER visits for heart attacks that's not a heart attack. So how do you deal with that? And with the sense of me being in menopause, I want to go for HRT, hormone replacement. Women's health tells me it's a great idea. Cardiology tells me it's a bad idea. How do you cope with that?
It's all you, Dr. Lay. Sorry.
That's a great question. That's why we're working on the menopause clinical guidelines. As a cardiologist, it is my responsibility to make sure you don't have the disease. So I need to rule out and assess all your risk factors, assess your risk before I say that it's the anxiety or the mental health issues that are making things worse. So I don't disregard the mental health issues, but if I haven't done my due diligence, if I haven't sent you for a stress test and check all your targets for the risk factors, I can't really say to you that it's all in your head. So, and if you have a mental health providers already, we communicate and see. And then as far as the hormonal replacement therapy, we also have an endocrinologist in Portland who has a special interest. So we discuss with the patient, so which matters to you most? And that is the question I ask all my patients at all their visits. If the menopause symptoms are just overwhelming and it's interfering with your life, then that is the most important thing to you. So we can talk about a plan to get you on the hormone therapy, but just understand that that can make X, Y, and Z for your heart worse. So maybe we have to increase your cholesterol medicine, let's say, but then give you the hormones so that your life's quality of life can be better.
I just want to foot stomp that the HRT decision is one that you make with your providers, and it's about what matters most to you now and what is causing the most negative impact on your life and your wellness and your well-being. So, individual decisions for individual patients with individual things being taken into account.
Yes.
Yep.
Thank you.